In healthcare, we deal with people dying every day. As healthcare workers, when it comes to caring for terminally ill patients, we try to focus on the patient's needs, which include relief of pain and suffering. Some argue that the relief of suffering includes preventing the patient's death, while others argue that if there is no viable treatment that prevents the patient from suffering, the next logical step is to provide a quick, easy, painless death. Death is defined as, quote, the irreversible cessation of circulatory and respiratory or neurologic functions, end quote. Physician-assisted suicide is a heated ethical debate in today's society. Recently in the news, this topic has been a common subject and continues to be a highly debated healthcare concern in the public. According to MedicineNet.com, physician-assisted suicide is defined as the, quote, voluntary termination of one's own life by administration of lethal substance with the direct or indirect assistance of a physician, end quote. Today we are going to present the pros and cons of this ethical issue.
Physician-assisted suicide was brought into the public view by Dr. Phsician in the 1990s. He helped many people pass away without suffering by using his invention called the Thanatron death machine. This may sound concerning, but his creation was made to allow the patient to die peacefully. The Thanatron was an IV drip that started the saline, and when the button was pushed, the saline would drop, and the drug thiopental would start to release over 60 seconds. This put the patient into a coma, and once the 60 seconds was up, a lethal dose of potassium chloride would begin and stop the heart within minutes. The patient would end up dying peacefully while asleep. Dr. Phsician was charged with murder and spent 8 years in jail. He stated, "My aim in helping the patient was not to cause death. My aim was to end suffering. It's got to be decriminalized." Many other physicians believe that Dr. Phsician's actions were not against the law and have similar views. Therefore, they believe physician-assisted suicide should be legalized.
These actions seem to start the heated debate of physician-assisted suicide. Since Dr. Phsician's actions, many states have passed laws supporting physician-assisted suicide, such as the Death and Dignity Act. In 1994, Oregon took the first step in legalizing physician-assisted suicide. Since then, society has changed its perception on death, especially with all of the technology that is being integrated into medicine. Leading to Vermont, Washington, and Montana also passing the Death with Dignity Act in their states. The Death with Dignity Act allows individuals to voluntarily request and receive a prescription medication to hasten their death.
At the core of a legalized physician-assisted suicide system is the principle that medical ethics should be governed and regulated by the professionals instead of the lawmakers. A physician-assisted suicide system puts the expertise of the doctor and the experience of the patient at the forefront of the issue and views both perspectives rightly as the most credible in given situation. The law cannot adapt to the specificity and multitude of ethical problems that arise on a situational basis. The law can only take into account circumstances that it perceives and can elaborate on. The highly personal and situational nature of this issue deems it insufficient for legislation, which exists outside the realm of the personal.
To ensure that a system maintains the highest ethical standards, numerous safeguards are implemented in physician-assisted suicide cases. To begin, the patient's condition must be either a terminal one, meaning incurable with no hope of recovery, and death imminent, or suffering irreversible medical conditions that cause him suffering in ways that they can no longer tolerate. Two doctors must overlook the case to verify the diagnosis and prognosis. Secondly, physician-assisted suicide can only be undertaken at the request or with the permission of the patient. For example, Oregon requires 2 written requests at least 15 days apart, an oral request, and other safeguards to ensure the suitability of the patient to make such a serious decision. Also, 2 doctors must verify the decision-making capability of the patient. Lastly, doctors must perform the task of providing means and administering, but only if necessary, otherwise the patient will self-administer.
The criteria further include the patient must be at least 18 years old, a state resident in either Oregon, Washington, Washington, Vermont, or Montana, capable of making and communicating healthcare decisions for themselves, diagnosed with a terminal illness that will lead to death within 6 months, and 2 physicians must agree on the criteria being met. Some further requirements include if either of the physicians question that the patient's judgment may be impaired, the patient must be referred for a psychological examination. The physician must inform the patient of alternatives such as palliative care, hospice, and pain management options. The physician must request that the patient notify the relatives of their decision, and use of the law cannot affect the status of the patient's health or life insurance policy. As we mentioned, there are strict requirements that both the patient and physician must adhere to. This means that not just anyone can request to end their life.
Patient autonomy is an important principle in every situation regarding healthcare, and is especially important when dealing with physician-assisted suicide. A patient should have the right to control the circumstances of his or her own death, and to determine how much suffering is too much. The patient is left in charge to make the decision of when enough is enough. In the case of physician-assisted suicide, in order to carry out the patient's autonomous decision, the physician should be capable of fulfilling their wish to end their life. The legalization of physician-assisted suicide would ensure that physicians could adhere to their patient's autonomous wishes. Therefore, patients die with dignity knowing that it is their choice.
In the documentary, How to Die in Oregon, Mrs. Cody Curtis was diagnosed with terminal liver cancer, therefore leaving her with no other options of treatment. She took pain medications once and felt that they made her incoherent and had no control for bodily function, therefore saying that she never would do that again. Mrs. Curtis explained that she didn't want her body to decide it was time to go, but that she wants to make a decision herself. Mrs. Cody states, "If I had the option, I would prefer not to die, thank you very much. Given that I know I'm going to die, does an extra 3 months of fluid leaking through my pores sound great? No, I would rather go when I am still feeling okay and can still communicate with my family." Death with dignity allows individuals like Mrs. Cody to make her own decision on when the right time is. Individuals with terminal illnesses never know what the next day has in store for them. Therefore, with physician-assisted suicide, the individual can peacefully live day to day until they have too much pain and suffering to continue on with their normal everyday lives. This allows the individuals to live each day to their fullest.
Another reason physician-assisted suicide is beneficial to the medical world is that it can help terminally ill patients end their suffering. Patients that are terminally ill are in tremendous amount of pain and can feel their bodies deteriorating. Physicians have an obligation to relieve pain and suffering and to promote the dignity of dying patients in their care. Therefore, if a competent patient asks for a lethal dose of medication in order to end their suffering, the physician has an obligation to help them relieve that suffering. For those with terminal illnesses, apart from the physical pain, the mental anguish caused by simply watching and waiting for death to come is also added. No one should have to go through this slow and hopeless process. The surety that death will come and nothing and absolutely nothing can be done about it is mentally exhausting. In addition, knowing that your loved ones are nearby, going through the same process of breathing as they too are watching you die, no one wants to see the people they care about suffer.
The legalization of physician-assisted suicide would allow the physician to have mercy on their patient. If a patient's pain and suffering cannot be sufficiently relieved with state-of-the-art palliative care, then the physician has an obligation to do everything within his or her power to relieve that suffering, even to the point of hastening death if there are no realistic alternatives acceptable to the patient. In this case, the physician would have mercy on his or her patient and therefore he would hasten their death and end their suffering.
Patients that have a terminal illness go through a lot of pain and suffering in their last months of life. I grew up in the country with raising many animals, and we didn't let our animals suffer, why let us humans? Miss Cody asked. Nancy Nezdeski, a woman who lost her husband to terminal brain cancer, states, "There are diseases that you cannot control. The side effects of a terminal illness can be way worse than dying.
If an individual were to decide to die naturally, hospice would be needed to help keep the patient comfortable until one day the end comes. During this time, the body's normal functions will begin to slow down and deteriorate, as well as the patient becoming weaker and even becoming bedridden. This leaves patients in situations where a great amount of assistance or even complete care would be needed for everyday care, such as using the bathroom and showers. Some individuals want to be able to take care of themselves and not put the burden on someone else to do so. To most of these individuals, it isn't about spending time by staying alive, but rather having this quality of life until the end of time. Ms. 30 days before her death, I thought that I would be able to drift away on my own, but my body is holding on too strong, and I know if I wait, that is going to be an excruciating pain. When it is time to go, you know. Additionally, with physician-assisted suicide, a set date is known to their death. Therefore, the family and friends can prepare themselves for their loved one's death. Mrs. Cody states, "It gives me a chance to think about how I want to leave things with them, my family and friends, in the end, like writing letters to my family and going through my items with my daughter. This also gives individuals a chance to have a live presence at their own funeral by assisting with the preparation and organizing of their funeral, which would allow the family to mourn rather than worrying about planning the perfect funeral. The patient can also make a decision of who will be present during the time of their death." Supporters of physician-assisted suicide state that another reason to legalize it in all 50 states is because it will reduce healthcare costs. The New York State Department of Health stated, "Under any new system of healthcare delivery, it will be far less costly to give a lethal dose of medication rather than caring for a patient throughout the dying process. Drugs for assisted suicide cost about $75 to $100, making them far less expensive than providing medical care. The care provided to dying or very ill patients, not just their treatment, is expensive and demanding for healthcare professionals. The extra weeks and months of caring for patients who do not opt for assisted suicide will seem all the more futile and costly. Physician-assisted suicide could help fill the void from cutbacks for treatment and care with the treatment of death." Healthcare costs is an incredibly important topic, as the single greatest pressure on healthcare today is financial. If physician-assisted suicide could reduce healthcare costs as well as carry out a patient's wishes to end their suffering, it would be a win-win situation. Those that oppose physician-assisted suicide may claim that patients will be encouraged to use the death dignity law of Oregon simply to reduce healthcare costs, but this is not the case. The Death with Dignity National Center stated, "No one is encouraged to use the law. To date, persons who have chosen to use the law have been well educated, have had excellent health care, have had good insurance, have had access to hospice, and have been well supported financially, emotionally, and physically. Absolutely no health maintenance organization or insurance company participates in this process." In addition to reducing healthcare costs, patients who choose to use physician-assisted suicide during their life may be able to donate their vital organs. Patients whose death is inevitable, who are likely to end their suffering early, may allow doctors the time and chance to examine their vital organs to see if they can be donated. At later stages of many terminal illnesses, organs are severely weakened and, in some cases, failing. It may not be possible to use them at this point. This will help alleviate the long waiting list there is for organ donation. Thus, legalizing physician-assisted suicide will not only put the victim out of his or her suffering earlier, but may also help save more lives. More than 100,000 men and women and children are waiting for organ transplants in the United States alone, with only 14,000 eligible donors. Physician-assisted suicide is an effective and ethical avenue to reduce this fast and fatal death.
In your argument, you addressed patient autonomy. You stated that the patient should be left in charge to make the decisions at the time of their death. While we agree that the patient should be able to determine their care, we would argue that this ability already exists in our current healthcare system. But if a patient feels that care is too intrusive able to control much of their pain and anxiety and help they use this path. But who's to say which diseases are chronic enough to choose the option of suicide? If a patient with an inoperable tumor can choose this option, why would a quadriplegic individual not be granted the same right? He may feel that his quality of life is deteriorated to the point that he would rather not be alive at all. Surely this patient does not deserve to suffer for years. Taking this point a step further, why would a patient with uncontrollable chronic depression be prevented from taking this action? If we allow certain patients with terrible suffering in their life, would it not be hypocritical to deny this right to other suffering patients? Both death and suffering are terrible, but we should not be so hasty to allow and encourage this option.
In regard to Dr. Kevorkian's invention, it has, without a doubt, changed life as we know it. However, the atomic bomb developed by the scientists of the Manhattan Project has changed our way of life too. The atomic bomb became the destroyer of worlds, as stated by one of its creators. The thanatron, created by Dr. Kevorkian, is like the atomic bomb. It is nothing more than an invention that has brought despair across the world. Physicians do not spend many years of medical school to give someone enough medication to induce death. Physicians are meant to help heal. As the oath taken by all physicians states, I will apply for the benefit of the sick all measures that are required, avoiding those twin traps of overtreatment and therapeutic power.
Finally, you also mentioned the ability for doctors to screen suicide patients for overdose. While this would help many people, a doctor somewhere might believe that the life of a patient with a treatable condition is worth more than one with no hope of recovery. What is to stop an unscrupulous physician from encouraging suicide rather than just offering it? Obviously, these situations would be few and far between. But there are many physicians in the world, each overseeing the care of many patients, and we owe each and every one of these patients protection as individuals.
Physician-assisted suicide has been romanticized too well in the eyes of the public and the media. As Westbrook states, legalization of physician-assisted suicide creates fear of abuses resulting from undue influence and coercion, financial incentives, inadequate determinations of mental competence, mistaken diagnosis of illness as terminal, inadequate diagnosis of depression, communication, and impatience of medical personnel. Many patients from various backgrounds have been diagnosed with a, quote, terminal illness, end quote, by a physician only to recover and live long lives past the days of their expected death. How would any physician know for a fact that a person was terminally ill? Claire states, a hospice nurse told me about a lovely 24-year-old given 3 months to live. 5 years later, she is still with us and the mother of a child.
Marker, the executive director of Patients' Rights Council, states, laws against euthanasia and assisted suicide are in place to prevent abuse and protect people from unscrupulous doctors and others. They are not and have never been intended to make anyone suffer. Now, there's been significant debate as healthcare payments with the style of public option payers as the federal government begins absorbing the costs on healthcare, a so-called death panel. While this is yet to be written into law, there is concern that eventually there may be significant incentives for the government to cut their losses and prescribe patients with certain criteria to not only be forced to end treatment, but to actively euthanize them. A case was heard by the Supreme Court called Washington versus Washington. In it, lawyers for Dr. Harold Westbrook challenged Washington State's ban on physician-assisted suicide, claiming it was the right of the mentally competent individual to determine the time and use of their death. In a unanimous decision by the U.S. Supreme Court, justices decided that the right to die was not protected by the due process clause. The due process clause states that when the government seeks to burden the individual's life, liberty, or property, the individual has a right to fair treatment and fundamental rights of the citizen will not encroach. The court found that a ban on suicide does not encroach upon the legal definition of liberty, deeply rooted in the nation's history, as cited in Moore versus East Cleveland, as the country has long held comprehensive bans on suicide. Chief Justice Brian Clinton, with the majority opinion, ruled, the history of the law's treatment of assisted suicide in this country has been and continues to be one of the rejection of nearly all efforts to permit it. That being the case, our decision leads us to conclude that the asserted right to assistance in committing suicide is not a fundamental liberty interest protected by the due process clause.
The act of a, quote, terminally ill person, unquote, seeking help to die from their physician's aid as a prolific concept of suicide is a normal thing. There is nothing normal or natural about suicide. If a person wants to die, then he or she was meant to die by natural causes such as disease, advanced age, etc. As St. Clair states, these laws create a world where everyone agrees it's okay to check out at certain times. In fact, we'll help you do it. We'll make it legal. Society approves. This creates more suicide among people who are not sick and leads to increased medical settlement. It creates incentives to do less medical research and save money on medical care by offering people poison pills. People in the past have dealt with terminal illness long before assisted suicide was discovered. Comfort measures were put in place just like today, only the technology we have now is not available. We now have advanced our knowledge to include more effective comfort measures to ease the pain patients feel when dying from an untreatable condition. In addition, medical errors occur everywhere in the healthcare setting, and physicians are part of those medical error statistics. St. Clair quotes, the Journal of the American Medical Association says, medical errors may be the third leading cause of death in the United States, at 225,000 deaths per year. Half are medical mistakes, including 2,000 deaths per year from unnecessary surgery, 7 deaths per year, 7,000 deaths per year from medication errors in hospitals, 20,000 deaths per year from other errors in hospitals, and 80,000 deaths per year from infections in hospitals. Should we be willing to trust a physician to be 100% correct every time when he or she determines a diagnosis? I think not.
Patient suffering should first and foremost be reduced and, when possible, eliminated in those settings. Today's medical professionals are able to drastically reduce the pain and distress. The patient experience is using a variety of methods, including, but not limited to, drug therapy, physical therapy, pain management techniques, and emotional therapy. As St. Clair states, quote, you already have control over your final health. Patients are not required today to undergo unwarranted treatment. In the case of patients dealing with cancer, chemotherapy can produce side effects that may seem embarrassing, debilitating, and downright tough to deal with. When the patient determines the treatment for their disease is worse than the disease itself, they have a right to autonomy, the right to make their own decisions for their own service. We as a society have created services for such patients centered around comfort, control, and dignity when experiencing the body's end-of-life process. These services often are centered in the patient's own home instead of familiar to the patient. This gives not only the patient a dignified end to their life, but also allows the loved ones of the patient the ability to say their goodbye. These services are widely heralded as a critical asset of the patient and the family, and without them, patient suffering would drastically increase. These services have become a viable option for essentially every terminally ill patient. If we were to allow and provide suicide options for the ill, we would actively promote that which every species and we as a culture have tried to promote and are rejecting.
Finally, medical professionals are ethically required to uphold the standard of non-maleficence, to do no harm. Would anyone disagree that physician-assisted suicide is doing harm to an individual? I doubt it. As providing a lethal dose of medication to a, quote, terminally ill, quote, patient, the physician is intentionally doing harm to the patient. Some may argue that the act could be doing harm to close family and friends of the patient, too. For close family and friends, physician-assisted suicide is doing harm by causing unnecessary mental and emotional stress. The whole process denies all involved the time remaining from the patient's life, time that can be used to ease the grieving process and decrease emotional and mental distress. Physician-assisted suicide should not be available anywhere. It benefits no one involved.
As the opposing side stated, when the patient determines the treatment for their disease is worse than the disease itself, they have the right to autonomy, the right to make their own decisions for their own person. This includes the right to end their suffering and end their life through physician-assisted suicide. As we stated previously, patient autonomy is important in every situation regarding healthcare. A patient should have the right to control the circumstances of his or her own death and to determine how much suffering is too much. With the physician-assisted suicide, patients die with dignity, knowing that it was their choice.
Secondly, as the opposing side stated, if a person was meant to die, then he or she was meant to die by natural causes. Individuals with terminal illnesses have a multitude of life-altering side effects that interfere with their everyday lives. The incredible amount of human suffering these patients have on a daily basis does not allow them to live their lives to the fullest. Yes, we have comfort measures to reduce the pain and suffering of patients who are terminally ill, but they do not completely eliminate the pain and suffering of these patients. These patients can physically feel their bodies deteriorating in some instances, making it impossible to care for themselves. Physician-assisted suicide allows terminally ill patients to make the decision to end this pain and suffering.
As the opposition stated, medical professionals are ethically required to uphold the standard of non-maleficence to do no harm. They asked, would anyone disagree that physician-assisted suicide is doing harm to an individual? As supporters of physician-assisted suicide, we disagree with this statement. Rather than the physician intentionally doing harm to the patient, like our opposer stated in their initial case, we believe that it's the physician's responsibility to relieve pain and suffering for patients. The physician can assist these terminally ill patients with their pain and suffering by providing life-ending medications. As stated in the initial case of Phsician, the act of terminally ill person seeking help to die through the physician's aid has supported the concept that suicide is a normal thing. However, with physician-assisted suicide, it is not the normal suicide that the general population would think of. Physician-assisted suicide allows terminally ill patients to help end their life.
In summary, supporting physician-assisted suicide is supporting a system that addresses the highly personal and situational manner of this issue, while enforcing ethical safeguards that protect against any form of abuse to the utmost degree possible. We refuse to maintain archaic laws in which the consent of the patient and expertise of the doctor is largely ignored. We believe that the support of physician-assisted suicide is supporting a flexible and ethical system that can address this complex situation with the patient and doctor in mind and at the forefront. Supporting physician-assisted suicide is supporting the idea that it is the state's role to create conditions where citizens can make optimal decisions for themselves amongst viable options. We do not support an atmosphere where the state destroys options and makes decisions for citizens, especially on the most sacred thing a person has, life. Supporting physician-assisted suicide is supporting a system that not only ends lives more humanely, but saves lives as well. We are not advocating a vast increase in quantity, but rather a quality increase in organ donation. We have stated that if these terminally ill patients are forced to live a long life, vital organs will become increasingly weaker, even if the disease does not directly affect specific organs. The system allows organ donation to be completed more efficiently, effectively, and even at all in some cases. The proposition offers quality of life over just mere quantity, choice on how to preserve this quality, and a way to preserve life of many people on organ donation waiting lists.
We as healthcare workers are charged with the care of our patients. That involves protecting them, vouching for them, treating their illness, and when that's not possible, preventing their suffering. The principle of non-maleficence states that an individual should do his best to prevent harm. The intentional death of patients, we believe, is doing harm. If this physician-assisted suicide is allowed, it could lead to a slippery slope that leads to patients not being able to choose for themselves fairly their own treatment. We, as healthcare workers, must protect our patients from harm, and physician-assisted suicide could lead to bad damages to patients everywhere. I'm Ron Byrne.